In this video, we will explore screening and the methods used for evaluating screening tests. But first, what exactly is screening? In epidemiology, screening refers to tests conducted on apparently healthy, asymptomatic individuals with the aim of detecting the presence of diseases or significant risk factors for diseases. By the end of this video, you will be able to describe the methods for assessing the validity of a screening test, discuss the relationship between prevalence of a disease and the predictive value of screening tests, and finally calculate the predictive value of screening tests with the aid of a contingency table. In terms of reliability, tests are often compared against a reference or a standard. Methodologies and instrumentation must of course prove within acceptable degree of confidence that repetitive testing will yield similar results. Validity, on the other hand, is a degree to which the evidence supports the interpretations and intended use of the results from a certain test. Essentially, was the test able to measure what it should measure? We can examine the sensitivity of a screening test and validate these results using the positive predictive value. Additionally, we can assess the specificity of a screening test and validate it using the negative predictive value. You can set up a contingency table, also known as a 2x2 table. It's called 2x2 because it compares two variables horizontally and two variables vertically. Horizontally, disease present and disease absent, and vertically, positive for disease and negative for disease. Of course, you want to give the table a title, and take note of the abbreviations here, as we will refer to them in the upcoming formulas. Sensitivity answers the question, are these people truly ill? So our focus will be on the proportion of cases that are your true positive or TP and false negative FN. Now, the formula that we will use is the ratio of true positive, that is TP, to the sum of true positive and false negative multiplied by 100. For specificity, we want to ask ourselves the question, is this person truly free of the disease that we're screening for? So here, of course, we will focus on the outcome group, disease absent, and look at the false positive, FP, and true negative, TN. To calculate specificity, we use a proportion of true negative, Tn, and the sum of Tn and Fp, then multiply that by 100. Let's look at this case example. Screening 100 men for prostate cancer. 10 tested positive during screening, while 5 more cases from same screening cohort who tested negative initially were confirmed to indeed have the disease using more advanced testing. For this, we will first look at specificity. You can pause the video and of course set up your table and work out the answer. Your table should look like this, and your answer here should be looking like that. Now, a sensitivity of 66.7% means that the test correctly identifies 66.7% of truly positive cases. In other words, there is a 66.7% chance that the test will detect the disease when it is present. Just to note that the lower the sensitivity, it indicates that the test may miss a significant proportion of actual positive cases. False negatives could lead to undetected cases, and this is especially concerning if the disease has severe consequences. Using the same case for prostate cancer screening, we can calculate specificity. Now, did they work this one out as well? Let's take a look. So here, a specificity of 52.9% means that the test correctly identifies 52.9% of true negative cases. It implies there is a 52.9% chance that the test will correctly identify individuals who do not have the disease. Now, this is not good. This low specificity suggests that there is a chance of false positive. Approximately 47.1% of individuals without the disease might receive positive results, potentially leading to unnecessary anxiety and follow-up tests among the persons screened. Earlier, I pointed out that we could validate specificity and sensitivity using positive predictive value and negative predictive value. Regarding sensitivity, we aim to identify persons with the disease of interest. Hence, positive predictive value tells us the probability of a true positive test. Specificity, on the other hand, rules out persons who do not have the disease. And so negative predictive value indicates the degree to which this is true. Based on how we designed the 2x2 table, we calculated column-wise for sensitivity and specificity, looking at the occurrence of disease. For positive predictive value and negative predictive value, we will perform row-wise computation to assess the degree of accuracy for sensitivity and specificity. Here are your equations. Now, let's take a look at this example on the outcomes of heart disease screening among 66,780 individuals. Now, I hope you, of course, remember your formula. You can go ahead and do the calculations here. Let's see how our responses compare. So in terms of the positive predictive value, that is 13.1%. A positive predictive value of 13.1% means that 13.1% of individuals who tested positive actually have the disease. If your PPV is above, say, 50%, this indicates that more often than not, a positive result is accurate. With this test, there's a significant false positive rate, 86.9%. This means that roughly 1 in every 1.2 positive results may be incorrect. 1 in 1.2, 86.9% false positive rate. Now, can you envision the problems that might arise from this screening test? Using the same example, screening test among 66,780 individuals, of course looking for heart disease in these individuals. In this example, we'll look at the negative predictive value. Now, again, row-wise calculations, and in terms of your response, you should be getting something like this. A negative predictive value of 99.9% means that 99.9% of individuals who test negative do not have the disease. NPV is relatively high in this case, indicating that negative test results are generally reliable. However, there's still that slight 0.1% chance of false negative test. So what is the relationship between these concepts and disease prevalence? Now, if the disease prevalence in the screened population is low, false positives become more common, affecting specificity and the positive predictive value. In this case, the 52.9% specificity means that a small false positive rate can lead to a considerable number of incorrect diagnoses due to the low disease burden in the population. Now, in a population with high disease prevalence, sensitivity and negative predictive value become more critical. The 66.7% sensitivity suggests that a substantial proportion of actual positive cases might be missed, and the 99.9% negative predictive value indicates that with a negative result, there's a 0.1% chance of false negative, which could be a little bit concerning in high prevalence settings. Screening tests should show reasonably good specificity and negative predictive value. The lower sensitivity and positive predictive value indicate a higher chance of missing actual positive cases and generating false positives. The interpretation and impact of these results depend significantly on the prevalence of the disease in the population being screened, with implications for both misdiagnoses and unnecessary treatment intervention. Your screening program should ideally be non-invasive as possible and very reliable. You could also look at the Wilson and Jugnos criteria for appraising the validity of screening program. Thank you for watching. Additional content on screening is available at immersionconcept.com/disease-screening.